First of all, I would like to thank you for your hospitality and high-level work. Actually, it's amazing, and it's a great pleasure that's being here and talking with one of the common problem that we're facing. It's a complication in spine surgery, which is a horrible thing for every surgeon. So to start with, nothing to be disclosed. This is a case report that's published with the author's names, and our talk will be, I will start with the take-home message, introduction, case presentation, discussion, and then conclusion. So I think that's the take-home message. That's this guy talking with his friend. That's I can't remember the last time that I had complication. And the reply from his colleague that he said that I can't remember that last time you did a post-operative remark. That means that everyone faced the complications. That's the guy who without complication is the guy is not doing surgery. Everyone know that. So the vascular injury in spine surgery, this is a case report. That's, as we know, that minimal invasive spine surgery is growing and expanding in the last decades of year, and vascular complications in the posterior approaches account about less than 1% with higher mortality rate at up to 65%. And the treatment could be, it depends on the presenting symptoms. So it could be intraoperatively or could be postoperatively. And in the lumbar spine, the most common level to be at risk of vascular injury is L4-5, while the left common iliac veins is the most common vessels to be injured, as the literature say. Our case presentation, he is a 46 years old, presented with back pain and left radiculopathy at the S1 dermatomes, associated with paresthesia with failure of conservative management for more than 3 months. At time of presentation, the SRL test up to 40%, muscle power, there was no weakness, and the numeric scale severity of pain was 7. This is as routinely done for every case in spine surgery, is dynamic view, and this is the MRI T1, T2, and the axial session was showed that the left L5 S1 huge disc. So planning for microscopic tubular discectomy was done, and it was, let's say, intraoperatively uneventful. We didn't face any profuse bleeding or some intraoperative complication, but the patient post-operatively start to feel whole left lower limb pain, diffuse, burning in nature, and which is different from the pain that he presented before the surgery, and the flexion that's partially relieve his complaint, failure of let's say strong medication, analgesic medication post-operatively, and when we attend to the, let's say, to the case on examination, there was a negative dorsalis pedis and popliteal vessels, while the femoral pulsation was positive. Directly, and he was hemodynamically stable. Then directly we consult the vascular surgeon, and vascular surgeon, by his ultrasonic detection, he said he confirmed the vascular injury and sent the patient to CT angio. At that time, traumatic pseudoaneurysm was diagnosed, and this is the CT angio picture that showed the coronal and the sagittal view, the site of, let's say, hematoma. And this is the CT angio, which confirmed the presence of the left pseudomeningeocele at the level of the 5S1 to the left side. And actually, that's what he did. He explored the patient. It was night, so he explored the patient next day in the morning, and the repair was done. It was both artery and vein involved, so he repaired both of them by synthetic graft, followed by embolectomy, and then follow-up patient. Actually, he relieved from the pain, and he stayed for 3 days in the hospital and discovered later on. So when we come about the, let's say, discussion, the first microdiscectomy was, let's say, innovated and started by ezer in 77, Their aim is to preserve the paravertebral muscle and decrease the postoperative pain. And the principal goal for MIS is, as I mentioned, is to preserve the paravertebral muscle. So it's become more popular and popular. And the pituitary rangule is the most common cause of vascular injury in which during disectomy. This is what published in the previous papers. And in our case, it was the first, in our case it was 5S1 rather than 4-5, and in the left-sided, and the injury is caused by pituitary rangule during microdiscectomy, and it was a left iliac vessels, and confirmed by CT. Repair was done by vascular surgeon next day. This is a diagram that's, let's say, demonstrate our injury risk. This is a tubular system that we are using. It's about 18 millimeter, and actually this is happening in our 4th or 5th case 3 years ago. So this is the mechanism that when using it through the tubular system, we are using the Kerrison, which is a risk of the injury at that time. So I think that's, as a conclusion, it's the first registered case injury in the tubular system. There were many cases registered with this, but specifically for a tubular endoscopic system, it was the first case. 5S1, it was not uncommon level, and the treatment was done post-operatively because the presenting is not so urgent. I have another case for TLIF, as we discussed yesterday with my friends. I faced it intraoperatively, and directly I explored the patient and saving the life of the patient also. It was another case, but I think that's vascular complication, although it's uncommon, but could happen any surgeon, anytime, and in any surgery, and ask for help in such catastrophic events. Don't stay alone. So thank you all, and I will invite you for our next events. It will announced later on, which is a basic in a medical research course. It will be done by AO Spine and Neurospine, might be within 2 or 3 months later.